Thank you very much, and thanks to Christina and colleagues for organizing, again, a wonderful conference, amazing data, and it's very exciting to see a lot of the basic science that we've been listening to over the last few years, coming to fruition in terms of developing therapeutics. So I have the pleasure of talking about some of our work funded by P20 Center when I was at Washington University on therapeutic regimens for treatment of UTIs. So these are existing treatments, but it's very infrequently used, mostly by urogynecologists, not really by primary doctors, primary care physicians, or even some urologists. And we really have used both our animal models as well as human studies to understand the mechanism of how some of these therapeutic regimens work, and using this, trying to change practice. So I'm very excited to share that. So I won't go through this in detail. Of course, UTIs, urinary tract infections, are extremely common infections, particularly in women, and uropathogenic E. coli account for a majority of UTIs, particularly in younger women, although other bacteria start, taking over a little bit in older women. And as we've heard over the years and know very well, a major complication of this infection is for not only their frequency, but also their propensity to recur and persist, leading to not only multiple recurrent UTIs and chronic inflammation, which alters the bladder environment, but also that these E. coli then strains are becoming more and more antibiotic resistant. And this is already a big problem in general, but then when we when women get to be postmenopausal, the number of the propensity to have recurrent infections increases dramatically, and is combined also with other chronic inflammatory conditions in the bladder. So it's particularly germane to understand why this happens and how we can make this better. So I'll just give very brief background on some of our studies in our animal model. We use young mice, about 2 to 4 months, as our sort of young control, and our aged mice between the ages of 18 and 22 months to represent women in their mid-60s and beyond, to study the impact of age on the bladder and frequency of UTIs. So I've shown this data before, so I won't because I really want to show the therapeutic data. So aged mice have a spontaneous recurrent UTI phenotype. So whereas young mice typically clear their acute infection within a few days, the aged mice tend to have recurrences. And we showed that this is the reason behind this is because they establish a larger number of reservoirs which can seed recurrent infections, which is the data over here, this increased number of reservoirs in aged mice. And the other thing that we see is that just at baseline, even without having an E. coli induced, aged mice have a much higher baseline inflammatory score, baseline circulating levels of inflammatory cytokines, as well as a whole host of inflammatory markers that are upregulated as the mice are aged. And I've shown this data before that the mucosal environment of the aged bladder is quite distinct from the young bladder, wherein the aged mice have these large tertiary lymphoid tissue that form in the bladder stroma, which we've gone to characterize in great detail and show that they're bona fide tertiary lymphoid tissue like spleen or lymph nodes with a bona fide germinal center that undergo a number of antigenic variation and B cell maturation and production of, just working as a entire germinal center. So just the fact that you have this now massive active lymphoid tissue sitting in the bladder where it normally wouldn't be, secreting inflammatory cytokines and altering the immune responses, you can imagine that the condition in this aged bladder is quite different than in young. And the other thing that we showed is that these bladder tertiary lymphoid tissue develop with age and start growing about the age of reproductive senescence, which is about after 9 months in mice. And I will show you in a second that this is the case in women as well, that it starts pretty much at menopause. Okay, and one couple of last things, because we'll touch back on this in a little bit, is that as the bladders age and these germinal centers are forming, there's a B cell maturation and production of plasma cells and an age-dependent increase in secretion of urinary immunoglobulin A, which is basically transferred from the stroma across the epithelium into the lumen. And this is significantly higher with age, presumably because of the plasma cells that are in there. What this IgA is doing is not known, but as I'll show you, some of the drugs that we use affect this as well. So it's possible that it's a response to the altered environment and response now that is to microbiota in the urine. And then the final thing that we've seen is, again, simply with age, that the aged epithelium has a significantly increased permeability. We do this by inoculating a labeled sugar, FITC-dextran, prior to sacrifice. In a young, unperturbed bladder, the FITC-dextran accumulates just in the superficial cells and then gets degraded. Whereas in the aged mice, you can see that it's leakier, and the FITC-dextran goes through all the layers of the bladder, of the epithelium, as well as into the stroma, showing that the aged epithelium is quite a bit permeable relative to young. And so now we'll switch to women. So first, we noticed that in an analysis of sera from postmenopausal women, which was anywhere from 50 years and above, with or without a history of infections, or rather without a history of infections, that there's higher levels of circulating IL-6, similar to what we noted in the mice. So there's a hyper-inflammatory response in general. And the other thing that we've noticed is that in postmenopausal bladders, by cystoscopy, we see these reddish yellow raised nodules with this cobblestone appearance. And this has been known for a long time, but historically has been considered benign, because any biopsy of these lesions are not cancerous. They never turn into cancer, and they're usually lymphocytic infiltrations and have been ignored for forever. And so we hypothesized that perhaps these nodules were similar to the bladder lymphoid tissue that we'd seen in our aged mice. And so we looked at these biopsies and showed that indeed they are tertiary lymphoid tissue, akin very much to what we've noted in the bladder. So they're classic, well-formed germinal centers with their B and T cell zones and an active dendritic cell, follicular dendritic network, which suggests that there's active engagement, similar to having lymph nodes inside the bladder in people. And this is just further analysis of these multiple lesions from multiple patients. So what does this mean? What does it mean that these exist? In mice, we showed that these were associated with increased UTIs and increased permeability of the epithelium. So what does it mean in people? So first, we looked at a large set of patient records. So we looked at cystoscopy and looked at women, postmenopausal women and some younger premenopausal women who had multiple history of recurrent UTIs, and then looked at cystoscopically whether they had these lymphoid tissue or not. And we found that these lesions called cystitis cystica or tertiary lymphoid tissue are quite prevalent in people, especially those who have a history of recurrent UTIs. And then when we looked at the various demographic details, we found that age and menopause, which in a woman are of course connected, are highly associated with these lesions, as well as pelvic myofascial pain, which could explain one of the reasons why there's so much more increased bladder pain conditions in aging women. And the other highest association was with prior history of UTIs. And even with multiple logistic regression analysis, age/menopause, menopausal status, and history of recurrent UTIs was most closely associated with having these lesions in the bladders. And so then we looked at what are these bladders doing? Are they protective, like they sometimes can be in the case of tuberculosis and lesions in the lung? But when we look in the bladder, we find that women who have these tertiary lymphoid tissue in their bladders are much more likely to have a recurrent UTI much earlier than women who don't have these tissues, so these lymphoid tissue in their bladders. So their existence exacerbates or is associated with an increased propensity to recurrent UTIs and shortening the time from one UTI to another UTI. So they're definitely not protective, rather they are pathologic. And so going to therapeutics, okay, so can we use therapeutics, a variety of therapeutics, and what can we do to improve these lesions or improve the health of these women? And so many of our urogynecology colleagues, and we're hoping that this expands to not just urogynecology colleagues treating postmenopausal women, but primary care doctors everywhere treating women with recurrent UTIs, is that we have a multimodal rUTI prevention regimen where, of course, there's antibiotics, which are only used to treat an acute UTI episode. We also give vaginal estrogen therapy. Of course, this is mostly relevant for postmenopausal women. And then we give an over-the-counter sugar, D-mannose, and then a methanamine hippurate, which is an FDA-approved agent, which is, which again is given, but they say that it stops breakout infections, but we didn't know how it works. And so we've systematically, together with my urogynecology colleagues and amazing fellows in the lab, some of whom have now gone on to faculty positions, really went through systematically each of these and looked at how they work and why they work. So I'll first tell you that together this multimodal regimen works. Because 78% of the punchline that this regimen works. And why does it work? One, we've defined that vaginal estrogen itself improves the inflammatory response in postmenopausal women. So it dampens the raised inflammation that occurs in aged women. So by dampening it, it creates an environment which is better, more conducive to recovery and prevention of future UTIs. And this is not a bacterial action, but on the host action. The other thing that we've shown again in our animal model is that vaginal estrogen therapy reduces the size and number of these tertiary lymphoid tissue, in part by dampening CXCL13, which is a monocyte-associated chemokine that is the initiation factor for these tertiary lymphoid tissue. Then the sugar D-mannose, we've shown very interesting. So D-mannose is given a lot because it's thought to chelate uropathogenic E. coli who love mannose away from binding to the bladder epithelial cells. But we've also shown that the other thing that D-mannose does is actually dampens the inflammatory response to UPEC infection, and most significantly stops excessive epithelial cell exfoliation, which occurs in aged bladders, in mice and in women. So it actually blocks the constant stress-induced sloughing of epithelial cells. And then finally, methanamine hippurate which is again doesn't induce resistance and it decreases our UTIs. We've shown that it actually is associated with increasing secretory IgA, both in our mouse model with infection as well as human, as in our women treated with methanamine hippurate. And we're investigating the mechanism of how increased IgA in the urine, is it recognizing uromicrobiota, or is it a response to the stress associated with aging, and is it a protective entity, because we know that methanamine works, and so we're looking into that. And then finally, and very excitingly, methanamine hippurate appears to work because it limits the epithelial permeability that we see in our age. This is again back in the bladder, but methanamine hippurate treated age bladders, you can see that rather than having exposure of fitsidextran all through the epithelium and stroma, it is limited to the superficial cells, and this is quantified here that it's only in the superficial cell, similar to the age bladder. So this is very effective to stopping that, and we think that starting epithelial permeability is one of the first steps to change for the age bladder, a changing landscape in the age bladder. And so if we can block this, we can block all the subsequent things potentially. And methanamine hippurate can be used in premenopausal women as well, which makes it an advantageous thing to use. And so so aged bladders have a very distinct immune landscape and response and much higher risk of recurrent infection. And then using our multimodal therapy, we're potentially able to systematically block individual changes that occur with age. And so understanding the mechanism of action of these therapeutic regimens, we can specifically target the various events that occur and hopefully be able to personalize treatments for our aged women. And so with that, I'd like to thank my group. Most of this work was done at WashU, but many of my lab moved with me down to Baylor. And of course, want to really thank our P20 funding from DK, which really kind of set up the group to do all these analyses. And we're recruiting to our new group at Baylor. And thank you for your attention.